is July 4th. Yeah, 4th of July, America, America. All right, welcome. This is the first presentation of the emergency podcast, not file service, at the Tierspital. So the topic of the day is verbal hands-off, as you see already on the screen. And I want to make sure that we start practicing these new skills of transferring a patient from one another. Now, we are going to have many shifts, as you all know, between interns, and there are a lot of people involved in each case. But as always ends up having the possibility that every single patient that is seen at any given time may end up being transferred to another person, even within the not-for service. Let's say a case comes in at 6 p.m. in the evening and stays in the hospital until the morning. Very likely, the interns that is working during the day or the evening will not be the one present in the morning to transfer the case to the receiving service. So what happens is that if you have some missing communication from you and your colleague intern that does the night, that missing communication will also last on the next step with added on possibility of further miscommunication or missing important elements. So what they did started from the human medicine, primarily in a on a critical care side, and it was done about 10 years ago. That's when it started. The studies that they have done were initially to evaluate what was the actual morbidity and mortality associated with errors in transferring the patient. And what they have determined is that nearly 100,000 patients a year, and those were pediatric institutions that were included in that study, about 100,000 patients would die in human centers, pediatric intensive care units, every year because of errors related to human mistakes or miscommunication. Based on the relevance of this information, there was a strong and heavy pressure to kind of find a way to reduce such mortality rate. And the issue is that doctors and nurses have always been transferring a patient to one another. With the new regulations and standards on working duties that have shortened the duration of shifts because of life quality or health issue for the healthcare providers, the number of people that every single patient will come from hand to hand has increased. And so, needless to say that 20 years, 30 years ago, if you did a night shift, you will start at 4 in the afternoon and you will work until 10 o'clock in the morning. That will make easy for you to be the only person in control for that patient for the course of a night and then transfer it to the person that was working during the day. Now, there's no such a thing as a 17-hour shift overnight, thankfully, for the health of who is working it. But what they've demonstrated is that shortening the shifts increases the risk of errors because of mistakes on transferring it. Now, doesn't mean that you need to go back and work 17 hours, which could sound fair to one side, but certainly is not survivable on the long term. But the key is instead formalizing the way the patient is transferred from one person to the other. So many attempts have been made over time, but finally, as I said about 10 years ago, they tried to formalize it. And they formalize it in a way that they use a randomized multi-center study to investigate the repeatability of the technique and how easy it was to train individuals at being successful from beginners and novice to become able to transfer patients without omitting anything relevant related to that patient. So what the system relies that is called IPASS, as you see here on this publication. This is just a summary of the main paper that came out in 2009. As I said, this is a summary from 2011. Is a mnemonic to standardize the verbal handoff. It relies on a standardized template for the written hands-off document, as well as evidence-based verbal handoff processes that are followed every single time you transfer a patient from one to another doctor, or from one nurse to another nurse, or from a student to another student, or even mixing the type of individual that you transfer the patient to. As I said, the trigger was a major publication that kind of was called an eye-opener publication entitled "Air is Human," so making mistakes is humans. But that paper showed the 100,000 deaths in kids in ICU every year because of human error. So the iPass system has now been recognized worldwide in every single intensive care unit in the world, as well as ER service, as the most successful way to decrease the chance of error. And that chance of error has decreased by 10-fold. That is a massive number. And if you think, when I'm going to go over in a few minutes about what the steps are, is actually the simplest way to transfer a patient. Meaning, if you have assessed your patient and you have concerns about that patient, before anything else, you express your concern as first. Instead of using the old school style of, this is Fluffy, is a 5-year-old male castrated German Shepherd that lives inside with no other dogs, goes to the park twice a week and eats Purina Pro Plan. The owner feeds him one gentle snack a day, and they play ball in the evening. He has been drinking normally and eating normally until a week ago. A week ago, he wasn't urinating properly, and then the owner took him to the vet, who administered antibiotic for 1 week. No blood work was done. 3 days later, he was still not urinating properly, and it was frequent urination with straining to urinate, so the veterinarian prescribed prednisone. Send him home. Today, the dog arrived and is not doing very well. Instead of having this sort of presentation that gives all the information that are needed, but they don't get to the point, it starts from the concerns that you have about that patient. Fluffy is the most unstable patient that we have in this ICU. The owner wants to resuscitate should anything happen. What I have done so far is ABC, because he presented for unable to urinate for the past 3 days. So that is a kind of how you revert the process. The first thing that now you know is that this patient is the most unstable in ICU. I don't care what the condition is. You already have the alert to the other person that is in front of you. He might know absolutely nothing of who Fluffy is, but he knows that Fluffy is the most unstable patient, in your opinion, in the ICU. Then you cover what are the issues that are related to Fluffy. So reverting that basically uses the same mindset that you'll be using when you're assessing your own patients. Like, oh, I'm not too comfortable about patient A. I'm a little uncomfortable about, I'm not really sure about patient B is doing. I'm really worried about patient C. So the first thing that you tell your colleague is, I'm really worried about patient C. About patient A, I'm not too worried. Stable. Patient B, I don't know. There are things to do. That is the first step of the iPass system. Now we're going to cover every step one at a time. But I want to give you a little bit of a sort of a treat of how the iPass system works. The iPass is actually a mnemonic where I stays for illness severity, as you see on the screen here. P stays for patient summary. A stays for action list. The first S is situation awareness and contingency planning. And the last S is synthesis by the receiver, which means that the last step of this process of transferring a patient is that whoever is receiving the patient from you will repeat what are the summary of the steps that you have just gone through. And that is done for each single patient. So if we look more in detail, now we get a little bit of a zoom here. No, that was a search. So we close the search, but we can zoom in like that. And then we go up and we move it up here, make it a little bigger so you'll read it better. Now we make it a little smaller because it went too big. There you go. You see that each class of the IPAS mnemonic will have a little bit of a description associated, and we'll see an example at the end on this publication. I will attach the PDF file of this little podcast to the end so you can read the whole article, and you can find all kind of resources about the better hands-off technique. As I said, if you go on the IPAS website, you find a bunch of resources. There are actually not only lectures, but there are even conferences that you can attend around the world on how this system can be implemented in any sort of institution, service, or clinic. So for illness severity, it's very simple. Stable, watcher meaning I need to keep an eye on it, unstable. The patient summary that you offer is a summary statement. Fluffy cannot urinate. That's basically your primary complaint. Fluffy was hit by a car. Fluffy has a humeral fracture. Fluffy fell off the 3rd floor. That's the summary statement. Events leading up to admission. Fluffy has been a healthy dog, but today went to the park, ran off a leash chasing a squirrel, and he got hit by a car. He was hit on the side of his body. From the time that he was hit, thereafter he was not conscious, he was lateral recumbent and remained unconscious until presentation. You told what are the events leading up to that moment. Hospital course, you say he arrived unconscious and lateral recumbent, non-responsive. We brought it to the trauma bay. We placed an IV catheter. We started an initial assessment. Pulses were present but weak. The patient was tachycardic. Neurologically was stuporous. We were able to elicit pain by deep pain palpation of the digits, but no other response was present. Pupils were anisochoric, and we had a high suspicion of severe head trauma, and we started initial resuscitation with fluids. Blood pressure at that point was not detected yet. At the time that we were administering the first bolus of fluids, we were able to detect blood pressure with a mean arterial pressure of 65. We continued the bolus, and after 20 ml per kilo, we had a mean arterial pressure of 75. Pulses improved, peripheral pulses were present. CRT was 2 seconds, mucous membrane were pink, and mentation did not improve at that time, so we administered a 1 ml per kilo of hypertonic saline over 1 minute. After following this, the dog started having better responsiveness, pupillary reflex returned to normal, palpebral reflex returned, and the dog was able to move the head. He seemed to be extremely uncomfortable on palpation of the cranial thorax, and suspicion for possible rib fractures was present. We administered pain medication. We used methadone, 0.1 mg per kg, and you just do your summary related to the hospital presentation and course. The patient, once was stabilized, had a CT scan performed under sedation on 2 mg per kg of ketamine and 0.3 mg per kg of midazolam. Hood showed rib fracture of the 3rd, 4th, and 5th left rib, and a skull fracture on the left side on the temporal bone. The patient now is transferred to ICU for continued care. Mentation is improved, hemodynamically stable. No abdominal injuries were detected. There's no effusion in the chest. Pulmonary function seems to be appropriate. Oxygenation is good. Is receiving ongoing oxygen, and is maintained in ICU on IV fluids and continued monitoring. The plan that we have is to discuss with the neurologist the skull fracture and the need for possible decompression if needed, or ignore it. There's no open fracture, so it's not considered an emergency right now, and neurologically the dog has improved and is now conscious. But also the respiratory function is another concern that we have, and and we want to make sure that we keep an eye on whether that deteriorates or not. We want to be cautious with fluid therapy because we know that potentially can worsen the degree of pulmonary water, so interstitial lung water. And so for that matter, we are going to do fluid therapy just to ensure that circulation is maintained, but being as restrictive as possible for that matter. And we are going to have ongoing neurological assessment to evaluate any deterioration. Blood glucose has been normal. We are rechecking it every 4 hours. And we called the owners an hour ago to give them an update. They signed an estimate for $10 million, and so we can do whatever we want. The owner has absolutely no limit for the money, but he definitely would like to have an update tomorrow morning between 8 o'clock and 10 o'clock. Communication was that the patient will likely be transferred to intensive care unit, and then the intensive care unit service will take primary responsibility unless the neurologist consultation decides that surgery is required for decompressive surgery of the skull fracture. That is a way you present the patient summary for that patient. I didn't say a word on what diet he was on. I didn't say a word on the fact that he had 3 UTI in the past. I didn't say a word about the fact that he also had IBD. Who cares? That is not the matter for this patient. That is not a matter to have in a transfer. But they should be absolutely aware that this patient had a neurological status. It was extremely compromised on arrival. And the second thing he would very worry about was the respiratory function. Those are 2 things that the patient, the receiver, doctor, technician, or students should not forget. The action list, again, the action list is what still has to happen. I have a coagulation panel pending versus whatever other test is still being reviewed. The CT scan full report is not ready yet. They just did a verbal report, so make sure to check if any other findings were in there. Timeline and ownership. I'm getting off this case right now, so this patient is transferred to you, and tomorrow morning at 8, the plan is to send to have a full transfer to intensive care unit, but with a neurology consultation planned to decide whether needs surgery or not. Situation awareness and contingency planners. Know what's going on, plan for what it may happen. You have done partially what you said in the summary, but what you say situation awareness. Neurological is better. Cranial nerves are good. We passed from stupors now to obtunded. With analgesia, it seems to be much more comfortable, but I'm worried that with those rib fracture, it might become painful again. We're not doing a constant rate infusion of drugs, but you may decide you think it's needed. So check for pain, because I don't know if it's going to need more. 2, neurologically, please make sure to keep an eye on it, because we were sophisticated over the past 2 hours. It did better, but I don't want it to lose what we have gained so far, and things can change, especially the fact that likely had some sort of increasing intracranial pressure issue. He responded very well to osmotic therapy, but he might need further intervention for that matter. The plan for what may happen. Now, if mentation deteriorates, make sure that you do a cardiovascular assessment to ensure that perfusion is okay, and that blood pressure, the mean arterial pressure, should be above 80 at any given time, because it's a head trauma case. So we want a mean arterial pressure on the high end than of normal. If you see that mentation deteriorates and the mean arterial pressure is too low, it needs to be fluid resuscitated. If fluid resuscitation reaches the point of that you're administering 20, 30 ml per kilo of crystalloids already, the next step would be repeating the osmotic therapy. If that does not respond, both from the cardiovascular standpoint and your mean arterial pressure and circulation don't seem to improve, you will start pressors. But at the same time, if the issue is the rise in intracranial pressure, at that point the patient should be intubated and ventilated, monitoring end-tidal CO2 between 35 and 45 and not above. The Synthesis by the receiver would be, all right, I got it. So Fluffy is, this is what is your concern, this is what you have done, this is what you're worried may happen, this is what I have to do to transfer it tomorrow. You'll be repeating all those steps. With this way, you will drastically decrease the chance to omit or mistakenly miss any aspect that is extremely relevant. Down here you have an example of a human patient, and we can just go over that just to close the first podcast. Here he says, sample of verbal handoff, illness severity. Okay, this is our sickest patient. It is a full code. Done. The I of the IPASS is done. Patient summary. AJ is a 4-year-old boy with a history of a X26 gestation, admitted with hypoxia and respiratory distress, secondary to a left lower lobe pneumonia. He presented with cough and high fevers for 2 days before admission. And on the day he presented to the emergency department, he had worsening respiratory distress. In the emergency department, he was found to have a sodium of 130, likely secondary to volume depletion versus syndrome of inappropriate secretion of antidiuretic hormone. He received a fluid bolus and he was started on oxygen at 2.5 liters. He is now on ceftriaxone. Action list. That is your patient summary. Action list. Please look in on him at approximately midnight and make sure his vitals are unchanged and his oxygen saturation is stable. Check to determine if his blood culture is positive tonight. That tells you that you can have positive culture pretty quickly, but apparently we don't do that. We are veterinary. Situation awareness and contingency planning. If his respiratory status worsen, please get another chest radiograph to determine if he's developing an effusion. Period. That's the action and situation awareness. Synthesis by the receiver. All right, I got it. So AJ is a 4-year-old, ex-preemie, admitted with hypoxia and respiratory distress secondary to a left lobe pneumonia, is on ceftriaxone, oxygen and fluids. You want me to check on him at midnight to make sure that he's stable and check on his blood culture. If his respiration status worsen, I will repeat a radiograph to look for an effusion. I think I have it. Done. That's to present a cat with respiratory distress. That's a very good surrogate of a cat with respiratory distress. So I hope that this was the first helpful hint of emergency medicine for the next year. And we'll continue tomorrow.